Okay, hi everyone, I'm Lorenzo, I'm part of the anaesthetic team in Genoa Vet. Okay, it's just a little brief introduction about anesthesia and diagnostic. So our role is to reduce atelectasis in CT bodies and to minimize motion artifacts and to provide cleaner and clearer images out of the diagnostic, not only for CT scans, but also in bronchoscopy, X-rays, RMI, and also in ultrasounds. Okay. So I would like to remind you that there is no best method, okay, doing anesthesia in every patient, in every technique. Okay, you can ask 50 different anesthesiologists how to perform anesthesia, and they will answer back with 50 different techniques. Okay, so this is our solution we find in our spaces, and you have to just identify what are your needs and understand what can you do for the best option in your facility and how to organize your work. So, when Chiara told me we are buying a new CT scan, she asked me what do I want for that and what do I need. Okay, I answered back immediately, I want a new ventilator because I'm an anesthesiologist, so if I can buy new toys, I'm happy, okay? But what I really need is some basic equipment. So I need dedicated staff, me or a vet tech. If you have a vet techs, they are great. So you can train them to do your work if you're not in the structure. I need intubation and a respiratory system, obviously, with O2 or with mixed gas. We need a basic multi-parameter monitor with end-tidal carbon dioxide and some non-invasive blood pressure. If you have an invasive pressure, it's the best, okay, for every type of anesthesia. And then I need the infusion line for the body on contrast and for the IV fluids during my procedure. If you have a ventilator, it's a lot easier, okay, because you have several alarms, several parameters to really don't care of because the machine will do everything. So why I'm here? I'm here because for the cranium and for the pelvis, for the front lips and the hind lips, there's no need for apnea. Okay, they have already shown you that. But for the thorax, for the chest, for the abdomen, it's really important to do the apnea because this machine suffers a little from motion artifact. So you have to really minimize them to have clearer images and to get the best out of a machine. So anesthesia, it's really simple, okay? It's just another anesthesia. It's just to try to extend the apnea, okay? The first stage of my anesthesia in CT scans is hyperventilation. You need to drop the EtCO2, the end-tidal carbon dioxide, under the level of 30, okay? So it can extend your apnea and triggers apnea. If you can do it for a short period, your apnea will last for a brief period. If you can extend for a longer period, 40 seconds up to 1 minute, okay, it triggers apnea very easily. If I can do it, everyone can do it, okay? And we have a minimum cardiovascular effect in our HDVI time, and we have very, very, very small inconvenience, no inconvenience at all in our 60-70 cases, even with unstable patients during our anesthesia. The stage 2 of our anesthesia is a little bit microbolus, I call it, of alfaxalone, okay, just like the propofol. It's a microbolus because the dosage is really small, 0.3, 0.4 milligrams per kilo, okay. In dogs and cats, it means for a dog of 10 kilos, you have to just put 0.4 ml of anesthetic, okay? just to extend your hyperventilation apnea and to make it last longer. Okay, you can go up to 1.5 minutes, 2 minutes, and it has minimal cardiovascular effect at this dose. You have a little bit of decreasing in MAP and increase in heart rate at doses higher, 1-2 milligram per kilo. Okay, and it's easy. You can. I always dilute the solution, and so I can make it slower on the IV. But I am confident with this protocol. But you can use propofol. You can use also ketamine. You can use fentanyl. Every drug that has a minimal impact and some mild respiratory depression can be used. Okay, I'm not so brave during my anesthesia, so if I'm feeling fine with my protocol, I stay usually with my protocol because I have a patient to look at. Okay, so step 1, hyperventilation. At the end of my hyperventilation, I do the kick dosage of anesthesia and the alpha dose bolus, and then we go for half a minute to up to 2 minutes. Usually in cats, I can do 2 CT scans in apnea if I'm confident with the patient. So we always do the pre-contrast and post-contrast scan. And if I'm not feeling safe on the patient, I can always enter in the room. I have a door with a window, so I can watch everything that happens during our anesthesia, and then open the door and I have my hands on my patients. Okay, so it's really, really, really safe. Again, minimal impact on the cardiovascular, no motion artifact, and it's safe. Okay, we've done 2.5 kilo cats, 40 kilo dogs, it's always the same. Obviously, if you have more stacks for the chest and for the abdomen, you have 4 stacks in bigger dogs, so you have to hyperventilate more. Okay, the more you hyperventilate, the more the alfaxalon kicks on the extending the anesthesia, but you are really, really, really safe. So I'm done.
It's an opportunity because it's very important.
Aspetta, tieni il microfono perché ci sono domande.
Thank you.
In between stacks, do you hyperventilate in between stacks?
No, I always ventilate. Okay, I do not hyperventilate if I'm waiting for my colleague to set scan. You can extend your apnea just with your ventilation. Do not hyperventilate again if you are not confident with it. But I usually do the hyperventilation, then the dose of alxan, then I wait. Okay, once we're done, I can enter, ventilate normally, and then you have to just wait for the next scan.